Hi, I'm Lucy Davis.
And I'm Hasan Tahir.
And this is Room for Improvement, the podcast dedicated to service improvement in axial spa care.
So on today's episode, we're delighted to be joined by one of our teams in Fife. And the theme for the episode today is talking around patient engagement and actually the power of self-management and how we really can use opportunities to work alongside the patients of our services to drive forward improvements, and how we really can get to the root of the problem by doing that.
So we're delighted to welcome Paula Dowie, Clinical Specialist Physiotherapist at NHS Fife, to talk us more about her project. Welcome, Paula.
Thank you. Thanks for having me.
No, pleasure. Paula, before you tell us about your service improvement project, would you like to tell us a bit about your service prior to the service improvement project?
Sure. We're quite a small team. We do have a dedicated spinal service, which is led by our consultant. We have, obviously, myself as a physiotherapist. We have a specialist nurse and a pharmacist. We also have ability to refer to a multidisciplinary team, including podiatry, psychology, and specialist physiotherapists for rheumatology, occupational therapists, and we generally were seeing people face-to-face. Obviously, prior to COVID, it was the consultant, nurse and pharmacist mainly doing the face-to-face appointments. And we tried different ways of running the clinic where the physiotherapist would go into different rooms. We trialled a clinic where the pharmacist and physiotherapist just worked together mainly, and we still weren't getting the results that we were looking for. We were slightly frustrated that people didn't seem to always be turning up for review appointments, and there were problems with physiotherapy engagement with regards to onward referral from those clinics.
So the question is, how do you have a dedicated? Did you have a dedicated AS service before, or was it just a general rheumatology clinic that you had?
Yeah, no, we did have a dedicated spinal service. We had clinics face-to-face running at that time. It was generally consultant, pharmacist and nurse that were seeing physiotherapists, and then they were referred on to the physiotherapist. So the physiotherapist wasn't actually in the face-to-face clinic all of the time, and we tried different ways of physiotherapy being involved in that. I'd gone into the different rooms of the pharmacist, the nurse, the consultant when I was required. We ran a pilot spinal clinic where myself and the pharmacist just saw patients. So we tried quite a lot of things and still felt that it was a little bit just unorganised, and weren't sure how best that we could set up the clinics to engage patients and provide them with the best service.
I mean, did you feel that in your previous service, what was the actual problem that you felt that needed addressing?
The problem was that we were seeing people year to year in the face-to-face clinic, and they'd often been referred to physiotherapy because we know how important physiotherapy is for the self-management, and they hadn't engaged with physiotherapy. So they would come for an annual review, being referred to physiotherapy, and all the same problems were present. So we felt that those appointments were frustrating because they hadn't engaged, they hadn't improved, they were seeing the same problems, coming up. And we're seeing that people weren't always aware of how to self-manage, how to access the services that were available in a multidisciplinary team. And we were aware that the newly diagnosed, even some of them weren't coming for physiotherapy. So we were really keen to work on ways that we could engage them better with physiotherapy and make sure that they came back to clinic appointments, because we also felt that there was a problem with attendance at the clinics. We were getting what felt like quite a lot of people not attending, so it was wasting appointments. Mm-hmm. And we were also getting people coming that were doing really well, and we didn't feel that they actually needed to come in for those appointments. So we felt we weren't using the skill mix and the appointments to the best of our ability.
And I guess that's frustrating for both you guys as professionals working in that service, but also it's not ideal for the patient either, is it? They're either not engaging in treatment that's the right thing for them to be able to do, and equally they might be coming to sessions and nobody likes to be coming to a hospital if they don't need to. So do you want to tell us a little bit more about how did you dig into that problem then? How did you understand the data that you had? How did you understand how people were feeling or why things were happening the way they were?
Well, through attendance at the Aspiring to Excellence programme, we'd had the support obviously regarding quality improvement strategies, and that really helped us break down what was the problem. Was there a problem? We were thinking that there wasn't a lot of people attending. So we looked first of all at the data. We started to look at the attendance at the clinics, got some figures, and looked at how many people were attending for physiotherapy that were referred from the different professions, from the nurse, from the pharmacist and the consultant, and then looked at using the driver diagram. What was it we were aiming to do? It was really to improve patient engagement and the self-management of flares of their axial spondyloarthritis. And then, what were the primary drivers around that? So it was really improving what people with axial spondyloarthritis knowledge was. How do we work around that? And then the secondary drivers, looking at what was their awareness and how could we improve that? For example, getting a physiotherapist in at the very start, and just using the plan, the PDSA, the Plan, Do, Study Act, and really looking at what we were doing, who was doing it, where we were doing it, when we were doing it, and then keeping on meeting up and looking at the data we were getting and what we needed to change going forward.
Paula, can I just ask you, I just want to just dive in a bit more just for our listeners. So we all have really similar issues, I'm sure. So how did you capture that data? So I just need to, in very simplistic terms, before we got, you found this is the problem. So you said that you were capturing the data that who was referring who to physiotherapy, who wasn't. How did you go about doing that?
It wasn't as easy as we thought it was going to be.
I can imagine.
We had to literally go back to all of the lists of patients and start to put it into a table, who was seeing the patients, did they turn up to their spinal appointment, and then were they referred to physiotherapy. And then we had to go to our, another system. We use a Tiara-based system for physio appointments. So then we had to go and see if they'd attended or if they had opted in. So in physiotherapy, we were using an opt-in kind of program at that point. So we would send out a letter to patients and they would opt in for an appointment if they wanted to, rather than always providing them with an appointment.
And so from your survey, what were the key findings prior to you embarking on the programme? Yeah,
it was showing exactly what we thought, in that only 60% of people were attending for physiotherapy from the referrals. So yeah, it was really good to see that data, and then, to work out after putting the changes in whether we're making a difference. And we have done, which has been fantastic.
And so just still, sorry, focusing on it. So you had only 60% of patients. And did you have so how did you go about, you must have had a feel for why maybe, and then that would then guided you to make those changes. So, I think you alluded to the primary and secondary drivers, but yeah, so any thoughts on that?
I think, especially when people are newly diagnosed, they were getting, possibly quite a number of appointments. It was all new to them, and it was up to them to get in contact with us to make an appointment. So that might be a good way of, improving the DNA, the do not attend rate, but actually not the best way at engaging and making sure that they have an appointment. And also people that were referring, like it was not a physiotherapist referring to physiotherapy, it was the nurse, the pharmacist and the consultant. And, they might encourage them to go for physiotherapy, but not being a physiotherapist themselves, maybe they didn't understand how physiotherapy could help them. And And we know with the delay to diagnosis that often our patients have had a poor experience of physiotherapy. You know, they've been waiting for quite a long time. They've not seen a specialist rheumatology physiotherapist, and therefore might not understand why physiotherapy would help. That was our feeling around it.
And I think something that you guys up in Fife particularly spent quite a lot of time doing through your project was really understanding that root cause analysis and what was causing those problems. And I think, as you've just described there, sometimes in quality improvement, we find that it's not just that one simple thing, that if we could just fix that one simple problem, actually, it's quite often possible causes of multiple different ways. And that then helped. And I think, obviously, feel free to correct me if I'm wrong, but I think that was kind of one of the key things, was really understanding those possible options and then trying to think about how you could respond to that by then thinking about those improvement actions you could take.
Absolutely. It was breaking it down and thinking of all the possible things that might contribute to that lack of attendance at physiotherapy. So that was really helpful in how we put in place the actions to change that.
So can you just talk about a bit more detail about those actions you did put in place, please?
Yeah, well, one of the barriers had been COVID during this project. So we had less face-to-face appointments, but actually that ended up providing us with an opportunity to really focus on our newly diagnosed people with axial spondyloarthritis. So prior to this project, the consultant had seen the person to diagnose them and to give a little bit of information about their diagnosis and then refer on to physiotherapy. So then we were in a position that we had less availability for face-to-face appointments. So there was a consultant appointment clinic of just 6 people, and we decided to try myself going into that clinic. So they would see the consultant, and then the consultant would explain the importance of not just the medical management, but physiotherapy and the rest of the team. And they would come in to discuss, how they were getting on. And then we would really talk about what was important to them and how physiotherapy may help them achieve their goals, who the rest of the team was, and improve the information that they had from a very early part in their journey to help them, educate them, make them understand how we could help them do what was important to them.
And so
I love that, Paula.
And so you felt by doing that improved their understanding and them knowing why they needed to come back and see you. Is that what you're saying? So therefore, the non-attendance rate actually improved because there was a bit more engagement with the different healthcare professionals, and they had a better feel for why physio was important. Is that the crux of it?
Yeah, and just making sure it's patient-centered. We may have referred them to physiotherapy before, but if they don't understand why and don't understand how it's going to help them, and even then discussing what type of appointment would suit them, because before we maybe just sent them an appointment for a face-to-face clinic, whereas often these people are working and they're busy, they have families, so it's important that we provide something that's appropriate for them. And with COVID, obviously we now have more opportunity for virtual consultations, both in physiotherapy and with our review patients. We can use that ability to see people without them having to travel, taking less time. And I could even discuss at the appointment, what time of day might suit them. So they're getting an appointment that suits them. They understand why they're coming for an appointment, and we work out their personal outcomes, their goals, and how we can work together to achieve those, so they understand the relevance of it.
I love that, Paula. And I think it's so great to hear you talk about that patient-centered approach, and that, actually it's quite a simple change, isn't it? Moving the physio into the consultant appointment there, and it's moving you into that space, but actually being able to give that information over and engage directly, being able to describe the benefits, actually thinking about it from the perspective of a patient who's been diagnosed with something they don't necessarily understand all that much at that point in time, other than it's causing pain and different challenges. That really just speaks to me in that simple way of actually putting the patient right at the centre, engaging them with all the information, and then and I think about how can we make sure that you do continue to engage with our service going forward. And I assume then that's then led to an uptake in your physiotherapy appointments going forward.
Absolutely. And I think time, especially at the beginning of someone's journey, is really important. And what we've found just in the way that it's been set up, they will see the consultant, she'll talk a little bit about the diagnosis and the medication, and she'll look more at the peripheral joints. And then they'll come into myself. So they've had a little bit of time to digest that information. And, I use quite a personal outcomes approach. And, what is it you would like to know? Finding out what their skills, what their strengths are, what they've found helps, and then how we can build on that together with the rest of the team, and who's appropriate, is occupational therapy or podiatry or even psychology an important part of their journey going forwards. And this is maybe things that they haven't been asked about before. I think that's been really helpful, just having that little bit of time for them to divulge the information and then talk about it in quite a holistic manner.
Yeah, absolutely. I mean, I think patient engagement is much better if you have part of that whole their journey is patient education, so they actually know what we're doing. I mean, especially with chronic conditions. And I love the fact that you also, I mean, I agree with you. Our cohort patients with access are young, and a lot of them are working. So especially when you get them back onto treatment as well, and they don't want to be coming in to lengthy appointments or waiting hours, and having to take a day off. So this whole remote ways of working is really good. But the other thing is, I mean, have you introduced an idea of patients booking in when they want to come and see you? Let's say patients who've been fairly stable. Have you looked in that? I think that part of your project's looked at that as well.
Yeah, absolutely. We've been concentrating that in the second part of our project. We have something in Scotland called open access. So it's a patient initiated follow-up, and we've been quite often referring stable people that are doing well into this open access, and they're delighted when they hear that they don't need to come for an annual review. Obviously, we have that discussion, and if that's appropriate and they want to do that, then what we will do is send them out a yearly letter just asking how they're getting on, making sure they know that they can contact our service. So they're not discharged, but they can access us at any point. And it means that we're seeing the people that really need that support from a face-to-face appointment, because we're not seeing those that don't need it, that are doing very well, and as you say, working and busy. But we have a helpline that they can come through, and they can come through physiotherapy. Obviously, they have open access to that. They can self-refer themselves to physiotherapy or access advice about anything through the advice line that we have.
And so that's Lucy is far cleverer than I am with QI stuff. This is the same concept as PIFU, isn't it? Patient-initiated follow-up that we talk about in England. Do you want to comment a bit about that?
Yeah, absolutely. I think it is exactly that ethos that you've described there, Paula, isn't it? It's about putting the patient at the centre of it. And actually, they are experts in their condition, and how do we make sure we're supporting individuals to make those decisions and have the right information to know where to go and when to go. And actually, we see through some of the work that quite a lot of our axial SPA services have some of these things in place, but it's not necessarily named in such a way. And I think for some of our more established services, that's been the case for a while. But I think what's really great in the way that you guys have been able to go about it in Fife is that actually, what does this really look like? What's really important? And it is, repeating myself again here, that patient at the centre approach and giving them the right information, education, just allows us to think about that. And we don't necessarily need to call it PIFU as such when we're talking about these things. It is about making sure we're allowing people to make choices that are right for them and can access care when they need it in the way that they need it at that point.
Absolutely. I think that's key to the way that we provide our services. It's what is most appropriate to the person. And we've established a criteria for who's appropriate for open access. And we're then auditing and making sure that the people that we're putting onto this open access are appropriate, and that we've looked at, for example, their stability with regards to their outcome measures, and made sure that they're appropriate, therefore, to go into open access.
mean, can I, that's really interesting, because that's what the next thing I was going to come on to is about the one little reservation I have is safeguarding. How do we know that if you leave people with an open appointment, they will contact you when they need to contact you, that we lose them because they're so good and years go by and something goes wrong. So this whole concept of safeguarding, what are your criteria to put someone on this particular pathway?
Yeah, I mean, their criteria are they're not on a biologic medication. Obviously, these people need review, that generally we feel that they have the appropriate education to be able to access when required. So I think making sure, for example, GPs know when to, recommend that people come back into our service. We've done some training with the GP trainees, for example, and with regards to the people that we're putting on open access, making sure that they know how to contact us and that when they should contact us. So having that discussion, working out where their strengths and their weaknesses are, and having that communication with them to make sure that they will contact us when they have a flare, if it's not settling after 5 days, when to use their non-steroidal anti-inflammatory medication, and if there are things that they can monitor themselves using some of the tools that we have available, like using online BASFI, the functional index, the disease index. They can score these themselves and use this as a way of working out if they need to get in contact with our team.
So you're capturing all this PROs, which is, I think that's great, because I think a lot of us really would like to do that, and some of us are certainly doing that. What is your mechanism of capturing these PROs?
We would like, as part of our project, to be able to do this more electronically, using the MySpa app, and we're working with the people that deal with IT to enable us to do that. At the moment, we are generally sending out the BASFI and BASDI scores and recording this when we do virtual appointments, or collecting it in a paper content at the moment, which is not ideal. But it does give us the breakdown of, how fatigued they are, what their VAS score is. So we've also worked as part of our project on the document that we do use for review patients, so that we have a standardized method of ensuring that we're collecting all the outcome measures, because the virtual appointments were new, and it's been easier in face-to-face to go through the format. But if you're doing it virtually, it's different, and we just need that standardization. And that's one of the things we worked in year 2, to make sure we're all getting the same information and learning from each other. And we now have a spinal MDT, a multidisciplinary team meeting, where we all learn from each other and discuss these things. And if there's people that are not self-managing, where they go to is a virtual appointment most appropriate? Do they need physiotherapy? And we've carried out some education with the team so that they know what our pathway is for flare management. Is it mainly they're going to physiotherapy now? And if we need to discuss with our consultant, pharmacist or nurse, then we have the spinal MDT format, so that we have a time put aside where we can all discuss people that are doing well and celebrate that, and also discuss people that maybe need a little bit more support to self-manage their flares.
Sure.
It all sounds like it's been quite straightforward for you, Paul, and that it's got a clear, compelling case for change in it, and the way you're describing it feels like it's just been a straightforward, easy implement. Is that a fair reflection? Have you had any challenges or barriers in your improving journey?
There certainly have been barriers. I think what we forgot in reflection was to communicate that we had changed the appointment type. So the way that our system works is that a generated appointment under a consultant's name for the rheumatology appointment, and we hadn't actually told the people that they would then be seeing a physiotherapist. So, for example, there were a couple of occasions where people had come and they had maybe their partner and their children waiting about in the hospital for them, expecting that they might be in for 20 minutes, and they'd come in and been in for a lot longer. And actually, a couple of them hadn't been able to stay to see myself because they hadn't allocated that time, because we hadn't communicated the length of time that they might be coming. So we've changed our paperwork going forward to make sure that they understand the kind of type of appointment they're coming for, and to even give them a couple of prompts of things they might want to be thinking, so they're engaging even prior to the appointment. So there was also a time where one of the people turned up and our consultant was off sick that day, so they were quite surprised to see me that they were already seeing in physio. And we knew that they need to change their medication, and not being a prescriber, I couldn't do that in the day. But so I think it's just communication. Certainly we've learned, and we have to involve all the stakeholders. I had discussed with our administration team about changing from an opt-in to an appointment-based physiotherapy appointment. But because of COVID and all the changes and the introduction of virtual appointments, I think we'd realised, looking at the stats, actually some people were still being sent opt-in appointments. So we had to have further discussions with the people involved in the appointments, and we changed our paperwork to ensure that we have a spinal box that's ticked and whether they're duly diagnosed. So it's really clear when we're doing the triage what type of appointment and who's most appropriate for that. So looking at our stats now, people are not opting in because they're giving an appointment. So it's gone from 60% people engaging to nearly 90%. It's 85.5% of people now engaging for physiotherapy, which is fantastic. And the difference is now that because they start at the journey speaking to the physiotherapist about how to self-manage, by the time they're coming to their first appointment now, some of them are really a lot better.
How else and what else did you do within that process?
Yeah, we looked at the information that we were providing to people and what was most appropriate, and we used the NAS booklets, and we also developed a number of helpful links that were provided in a pamphlet, for example, with some links for mental health resources, for work, for exercise, and again, links to the NAS website and the MySpa app for using exercises. So we really looked at what information could they access, online or through the great pamphlets that NAS provide.
And I think what you've really nicely described there as well is actually that PDSA cycle in action that we discuss a lot in the programme. And you can find videos about some of the quality improvement tools on the NAS website if you wanted to have a little bit more information about those. But a PDSA cycle in essence is around testing small changes and doing it quite quickly. And that refinement of your information with your admin team and the refinement of the forms and the information you give to the patients are all examples of those really small tweaks and tests of change that mean that actually we don't just assume we implement a service and it's going to be spot on first time round. We know we might not get it right, but actually what we want to do is keep looking for those opportunities for improvement. And what you've described there to me just absolutely showcases that benefit of using PDSA cycles and small tests of change to really get to a place now where you've got the vast majority of patients accessing and hearing that you've got people coming actually better to that first appointment with physio is just mega, isn't it?
It's brilliant. And that's why we do what we do. We want to help people help themselves get better without, always needing us to be there. They can self-manage, and that's ideal. And that's what gives us that job satisfaction to see people being able to do that.
That's a great story. 60%. From 60% to 90%, so 30% improvement or a third improvement is phenomenal. So just for our viewers, would you mind just giving us some top tips on how to get patients engaged?
Yeah, I think first of all, look at if it is a problem, get the data and then think about what your aims are and break it down so that you have a clear plan of who's doing it, what your primary drivers are, your secondary drivers, and then work around those to achieve what you're looking to do, and keep examining the information, do your PDSA cycles, so use these quality improvement techniques, look for advice or support. We've been really we've really had the help of the transformation unit and the Aspiring to Excellence, but having that time set aside to keep examining it, to meet up, to keep looking at your information is really helpful. And I think communication is key. It's communicating at all stages with the people that are using your services, and the way that you communicate with them, using a style that puts them at the centre and helps them to develop their programme and to be the ones that decide how they move forward.
So thank you so much, Paula, for joining us on this show.
It's been an absolute pleasure. Thanks very much for having me, and thanks to NAS for all the support they've provided to our team, the transformation unit and the Aspiring to Excellence programme, and the ability to discuss that with all the other teams. But thanks very much for having me.
Yeah, and finally, I'd really like to thank all our listeners over the last 6 episodes. And please do send us your feedback by visiting nas.co.uk/room for improvement. And please follow the links to the survey. Thank you so much.
This is a CPD accredited episode. To collect your certificate, please email aspiringtoexcellence@nas.co.uk and quote the code Paula. Room for Improvement is brought to you by the Aspiring to Excellence programme from NAS, which is sponsored by AbbVie, Biogen, Lilly, Novartis and UCB, and in partnership with BritSpa and the NHS Transformation Unit.